Dear friends, good evening. This is Rajat Mathur, and I am on behalf of Ambala Ophthalmological Society. I welcome you all for this webinar. This webinar is being held under the aegis of Retinal Ophthalmological Society. The topic of discussion of this webinar is the new drug called brolucizumab. We have eminent ophthalmologists and retinal surgeons as speakers, Dr. Manoj Khatri and Dr. Boral. And our new retinologist, Dr. Megha, is also there. And we have two senior retina surgeons as Dr. Ruchi Mittal as moderator and Dr. Mohit Bansal as panelist. So let's get enriched by their experience with the new drug. I welcome Dr. Ruchi to give the introduction. Dr. Manoj, please.
Good evening, all of you. So today we are going to discuss the experience of this new drug, brolucizumab. And as we all know that we have lots of anti-VEGFs in our basket, like pegaptinib, Avastin, ranibizumab, and aflibercept. And this is a novel drug. So we really want to know the experiences of our eminent speakers today. So first of all, I'll welcome Dr. Manoj Khatri. He is the Managing Director of iDocs Eye Hospital, Chennai. He has an enormous list of degrees and fellowships to name. He has been awarded as Best Outgoing Postgraduate from SRSMC Chennai. He has been a part of various studies and research clinical trials. His academic interests are diabetic retinopathy and age-related macular degeneration. He is an excellent surgeon and clinician. I welcome you, Dr. Manoj Khatri, for your talk.
Thank you. Okay, I'll be with the first speaker.
Yes.
Okay. Sorry. Good evening, everyone. Just give me a minute. I'm just going to start the screen share.
Sure.
Is my screen visible?
Yes.
Okay. Good evening, everyone. Many thanks to the organizers and special thanks to Ambala City Ophthalmics Association to give us this opportunity to be all of us together on this wonderful platform. The topic given to me today is management of neovascular age-related macular degeneration, optimizing anti-VEGF therapy through long-term fluid control. Let's see what we are learning in this era of anti-VEGFs, which is changing at a very rapid pace. And it is also telling us not to get good control of our patients, but also, giving them extended anatomical and visual outcomes and stabilizing the retina over a period of time. Because it's a retina symposium, just a small disclosure, disclaimer. What I've done is I've divided my talk in a couple of subheadings. First is what is an overview of neovascular AMD? What are the unmet needs in neovascular AMD? What do we really mean by fluid and what is the current understanding of fluid? What is brolucizumab? What is the current understanding with Hawk and Harrier trial? And what is our real world experience with brolucizumab? And in the end, a small summary. As we know, age-related macular degeneration is a leading cause of severe and irreversible vision loss worldwide, and it is going to affect more and more number of people. Neovascular AMD is characterized by fluid accumulation. This is a known fact, and if left untreated, results in severe and rapid vision loss. We are not behind the statistics from Caucasian population. The AMD is also one of the leading cause of blindness in India now, and we are at the threshold where more and more patients are requiring the treatment nowadays. There are two different aspects when we think about treatment for any different patient, any patient for us. One is unresolved fluid, and one is high injection burden for neovascular AMD patient. Now let's understand brief points. What I have taken from a lot of clinical trials is what is unresolved fluid. What we have seen is more than 50% of eyes had residual fluid after 2 years in real world patients. They receiving treat and extend regime with aflibercept, ranibizumab or bevacizumab. We are not saying these molecules are bad, but this is a real world situation. You know, the unresolved fluid is one of the major risk and the burden for us, as well as the high injection burden. You know, getting patients, especially in this post-COVID era, is a big challenge. Getting them every month to your OPD, seeing them, doing scans. So more than 50% of patients receive injection often than every 8 weeks at 1 year follow-up in real world studies. So this is a cause of concern. Why so? Because we need adherence to challenge for treatment, and also the non-adherence part which we have to take out. So this we have to understand. Now, if we look at the PAT survey done by ASRS member, that is American Society of Retinal Specialists, which we were also part of it. In 2018, the survey told us that reduced treatment burden is one of the major risk factor in identifying treatment and monitoring burden as a key unmet need in neovascular AMD management. So reduced treatment burden is one of the factor which we have to encounter. Okay. Indeed, monitoring visits are the most time and resource consuming part of a patient care with anti-VEGF therapy for individuals with neovascular AMD. What happened in 2019 survey, similar survey was done by Vitreoretina Society of India as well. And that in that also we have realized that insufficient fluid resolution, that means insufficient resolution or suboptimal treatment outcome of anti-VEGF therapy for neovascular AMD is one of the major factor for clinical reasons to switch over between different anti-VEGF subgroups, whether it is brolucizumab, whether it is aflibercept, ranibizumab, or bevacizumab, or a biosimilar. So this was one of the major challenge. Relevance of retinal fluid in neovascular age-related macular degeneration has changed over a period of time. And what we have understood is any fluid related to secondary to neovascular age-related macular degeneration is pathological, whether it is intraretinal involving the inner retina or outer retina, or it is subretinal, or it is sub-RP. The amount of fluid present, the duration of fluid present, everything has a role, and it damages the receptor photoreceptors over a period of time, and also leads to kind of atrophic changes over involving the retinal pigment epithelium. So involvement of fluid in current understanding at any level, both in retina and subretinal level or sub-RP level, is considered as pathological if it is secondary to age-related macular degeneration. Now, if we look at the data from CAT trial, this trial told us that bevacizumab is one of the best molecules available. We all agree, because most of our patients, they need bevacizumab. We cannot just discard this bevacizumab out of our armamentarium. But it also told us a couple of other points. First, it told us about subretinal fluid, which was commonly seen in almost more than 80% of the population with choroidal neovascular membrane. The second most common was intraretinal fluid, and lastly, almost about half of the patient had a subretinal fluid, sub-RP fluid, sorry. So sub-RP fluid is also pathological, but it's seen in less number of patients. So fluid as a component of neovascular age-related macular degeneration disease activity was seen at almost all the levels. What is the clinical relevance? Now, we know fluid is pathological, fluid there, you have to treat it, but what is this role? Why you want to treat it? First is in diagnosis. As we said, OCT is one of the game changers, especially the Opta has changed the way we are managing this patient, that is OCT angiography, especially in the last 3 to 4 years, is one of the game changers for neovascular AMD management. Time to first treatment, the shorter is the time, the earlier we treat, the better is the visual outcome, both anatomical and functional. The disease activity, fluid is an indication of active disease, mandating further anti-VEGF therapy. Visual outcomes are directly related to the time of treatment and also the extent of the disease and so on. So the earlier we treat, the better out the outcomes. The stronger agent we use, the better out the outcomes. We all know that. And treatment interval, like durable therapies to control fluid and get better visual acuity gains and reduce treatment burden in these patients. In real world scenario, also fluid drives retreatment decision, especially in the presence of subretinal fluid and intraretinal fluid. Visual acuity loss was not a consistent trigger for retreatment. Okay, so presence of fluid is one of the major indication in real world scenario. If you look at the data from some more trials, absence of fluid, whether it is intraretinal or subretinal fluid, leads to better visual acuity outcome. This is what we know. More visual acuity gains is seen when there is a macula is dry, and anatomically it also functions well. So we have both the advantages of this. Increased fluctuation in fluid volume were associated with poorer visual outcomes by 24 months. So if I look at this data, where there is no fluid fluctuation, in the sense there is no volume of fluid which is fluctuating, like coming and going, coming and going. And if you look at the quartile data, quartile 1, quartile 2, quartile 3, and quartile 4, the most marked difference in visual acuity was seen for total fluid in eyes with most variability compared to eyes with least fluid variability. So whenever we have a least fluid variability, that means waxing and waning of disease, the visual acuity and the anatomical outcome is much better. In addition, eyes with most intraretinal and subretinal variability, as compared with eyes with intraretinal and subretinal fluid, the quartile functional is better. So this is a known fact even involving most of the major trials. And a consistent correlation between fluid and BCVA was identified in initial phases of treatment. This is what fluid study post-hoc analysis tell us, that the lesser is the fluid, the better out the outcomes. The correlation between fluid and BCVA was dependent on fluid type as well as distribution. So the more fluid is there in the right in the center of 1 millimeter zone, so the more poorer is the visual acuity. Now, what we understand with brolucizumab and what it does to fluid in terms of a newer molecule, let's look at the anti-VEGF per se as a whole before we start talking about brolucizumab. So this is something, a chain of antigen antibody, of an antigen and anti-VEGF looks like. The brolucizumab is the most clinically advanced single chain antibody fragment. But how do they discover? So if you look at the structure of bevacizumab, this is the structure of bevacizumab. We have two Fab fragments, and then we have a FC fragment. They are joined together. So the molecular size is bigger. That's why the penetration is less. But when we look at the ranibizumab model, this is a ranibizumab model in which only the upper portion was taken. And then you have a CDR, they are complementary determining region. And when in brolucizumab, what they have taken is two CDRs, and then they joined with a peptide range, which is these are like proprietary human SCF5 fold. And when they are joined together, the molecular size is much, much lesser, and the penetration is deeper, and also it stays in the contact with the desired area much longer. So this is where we are as compared to aflibercept, ranibizumab, bevacizumab, and brolucizumab. So this is what is the structural difference. In aflibercept, the peptide chain is on the top, but what happens as a staggering difference is this, that is relative number of molecules per injection present with aflibercept is only 1, ranibizumab is only half. That doesn't mean these are inferior molecules. They have their own role to play, even in the era of neovascular AMD management. But if you look at the same thing for the brolucizumab, the availability of this drug goes to almost 12 to 13 molecules per injection. This is a very significant change. And also the size of the molecule is less, though the dose is higher, but this has been well tolerated and the efficacy has been well documented with this kind of dosage. Now, what they did in Hawk and Harrier trial, Hawk was done majority with US population and Japanese population. Harrier was for the European population. They did same thing what we have done in the past, and what we know the fact of aflibercept, that is give monthly loading dose, then space this injection over a period of time to almost 12 weeks rather than 8 weeks what we do in aflibercept. So you are having a treatment-free interval for almost 3 months. This is a big change. And they have also shifted this patient as and when required, suppose if there is a worsening. However, the most significant change came in the central subfoveal thickness and best corrected visual acuity, which has told us that it is much superior than aflibercept, both in Hawk and Harrier trial. If you look at this graph, over a period of 96 weeks, which is a very long period of time, which the data has been studied. And when we see this change, the visual acuity gain is much superior than aflibercept, as well as the central subfoveal thickness analysis. And this is one of the very important graphs which I found as quite interesting is you see the fluctuation with aflibercept. I'm not saying it's an inferior molecule, it's a wonderful molecule. It still has its role to play. And we in last 3-4 years, I'm saying like we were using it a lot. But the fluctuations in fluid is much lesser, and the central subfoveal thickness is very well maintained with brolucizumab. So it tells us that brolucizumab has a superior drying effect and also superior functional outcome effect as compared to aflibercept in both Hawk and Harrier data. Does this translate to taking care of the intraretinal and subretinal fluid? Yes, it does translate to taking care of both the fluids, and also have been seen that consistently the effect have been seen and monitored at 16 weeks, 48 weeks, and 96 weeks. So it has a superior drying effect, and fewer patients had sub-RP fluid, which is one of the most pathognomic feature of choroidal neovascular membrane. The sub-RP fluid was very less in brolucizumab group as compared to aflibercept group in both Hawk and Harrier trials. Cumulative incidence of more than 3 consecutive fluid-free visits were up to 96 weeks, as you can see here. It was much more achieved with brolucizumab group rather than aflibercept group. So definitely there is a superiority of the molecule. The efficacy is there, superior drying effect, both and improving anatomical and functional outcome. And over 50% of brolucizumab 6 milligram patient maintain dosing interval of Q12, that is every 3 months until for week 48. So this is also very exciting to know that this patient don't need monthly treatment. So this is one of the major outcome. And post hoc analysis also told us in eyes with early persistent retinal fluid, numerically greater visual acuity gains were observed with brolucizumab compared to aflibercept. As what we can see here, it is almost 6.4 as compared to 3.7. So this is one of the major change and what we have understood, and also told us that higher proportion of these patients achieve BCV of more than 15 letters with brolucizumab compared to aflibercept. So early persistent retinal fluid, brolucizumab achieved superior greater CST reduction from baseline versus aflibercept. All this data, can it translate into clinical experience? That is what is a major challenge and major question. And what we learned from our colleagues from US who have almost crossed more than 70,000 injections. And I think brolucizumab in India has crossed close to is up to close to 2,000 injections. And it was available to us from October 1st week, if I'm not wrong. Whether in the US, it was almost had its anniversary altogether. So we had a very good meeting on 27th with a few of our American counterparts, learning about the molecule and what is their experience and what is our experience. It's not of a big difference. What we have learned, we can start this therapy in both treatment naive as well as recalcitrant cases at one of the first choice. To share a couple of examples of my patients, definitely a thorough baseline workup for all these patients was done, including indirect ophthalmoscopy to be seen by the retina specialist, because now what has happened is anti-VEGF has become a panacea of treatment. So most of the time we are not even seeing our patient. Someone else is seeing the patient, you are injecting, or you are seeing the patient, someone else is injecting because of the treatment burden. But I made sure that brolucizumab patients were seen by me personally, each and every patient, just to make sure that we don't encounter any adverse effect in the initial experience. So this was the first patient, 63-year-old male, occult CNVM treatment naive. As you can see here, he had a penetrating keratoplasty as well as retinal detachment surgery in past. However, the inner retinal contour was quite well maintained, and he had a very good outcome with a very thin epiretinal membrane here. But I thought let's minimize the number of interventions, because this patient already had many interventions in the past, and treated him with brolucizumab. And within 2 weeks, what you see here is, such a good anatomical and functional outcome. The patient was very comfortable and happy with his visual outcome, and he is doing quite well. We have a recent OCTs of follow-up as well. We have not included due to lack of time. Another patient of mine, he was treated by me, before October 2020 of the availability of brolucizumab with aflibercept. I'm not saying aflibercept is an inferior molecule. Most of these patients were on aflibercept, but the treatment response was slightly slow as compared to brolucizumab. So this patient has a PED, though it's a notch PED. There was no component of idiopathic polypoidal choroidal vasculopathy. He had a EMD CNVM. And what you see here is a September 2020 scan. And this was post aflibercept, not much of a change. You see here pre and post. So it doesn't make the aflibercept as an inferior molecule, but the treatment response was slow. But this is again after one more aflibercept, the fluid here is a pre-RP fluid started coming off, and this was the time when I counseled the patient in November, and I said, let's shift over to aflibercept. And this is what, sorry, brolucizumab, and this is what happens after first injection of brolucizumab in December. Such a good treatment response. You can see here the PED has significantly reduced with the drying off of the fluid in both sub-RP and sub-PED space, and also a very good anatomical and functional outcome. Over a period of time, after second brolucizumab injection, the near normal contour of the retina was achieved. The PEDs are nicely flattening out, and retinal and choroidal contour is returning back to the normalcy. Another case has occult CNVM treatment naive-wise. One eye we already lost due to scarring due to CNVM in this patient. So he was under treatment by me, but the scarring was at a very rapid pace. We are not able to do much. But when he came for the first time, I said, no, let me start you with brolucizumab itself. I don't want to, have a chance of you getting scarring in this eye. And what you can see here immediately post 2 weeks, we are following these patients every 2 weeks. One, to see adverse reaction, and the second most important point to see here is the response to the drug, as well as to our understanding. We need to improve as how the drug is working and what's happening, to the functional outcome of the retina as well. So as what you can see here, this is pre-treatment and post-treatment immediately very good response. After 1 month of brolucizumab injection, though the CNVM was flattening quite nicely, we said, okay, let's give one more injection. And this patient is still on follow-up with us. So just to summarize, all fluid is pathological in neovascular AMD in current situation, and multiple studies have confirmed this, that dissolving fluid is key to achieving optimal BCV outcomes and longer retreatment intervals. Greater fluctuations in retinal fluid volumes. This is one of the key factors derived from all these trials. During the maintenance phase of any anti-VEGF treatment in neovascular AMD is associated with worse outcome at the end of 2 to 3 years. So we need to be careful about selecting these patients and also counseling them. And in both Hawk and Harrier trials, fewer patients on brolucizumab had any kind of fluid at weeks 16, 48, and 96. So we are achieving a fluid-free interval. And sustained dryness of retina was achieved faster in brolucizumab treated patients versus aflibercept, and hence fewer number of injections were required in those patients compared with aflibercept. So this is one of the major key take-home messages from all these trials, and also for our clinical practice. And patients with early persistent retinal fluid had numerically better BCV outcomes observed with brolucizumab compared with aflibercept. So does this say that brolucizumab, when it is available in your armamentarium, is the drug of choice for all patients? I will still say no. We have to be very, very vigilant in choosing our patients, counseling them, seeing them, try to look out for any kind of triggering factor which can cause intraocular inflammations and also on in post-injection period. So read all the fine prints very carefully, read its trials very, very carefully. Talk to your colleagues, and also let's collect more and more data. That's what we are trying to form a consortium group across India. Let's have more and more data from different regions so that we understand each other's experience and learn and give best possible treatment outcomes to our patient, valuable patients. Thank you very much for a patient hearing, and thank you so much, Ambala Society, for giving me this wonderful opportunity. And we'll start seeing each other face to face quite soon, and looking forward to meeting you personally very eagerly. Thank you so very much once again.
Thank you very much, Dr. Manoj. It was an excellent talk. So we'll just move forward to our next speaker, and then we'll take over the questions for discussion. So our next speaker is Dr. Shubhendu. He is a senior VR consultant in Disha Eye Hospital, Kolkata. He has presented various papers in national and in. Sir, you can stop sharing your screen, Dr. Khatri.
Hello.
Hello, Dr. Gulal.
I'm just on the way. I'm not even at home.
Okay.
So I'll be there within 5 minutes.
So we start with Megha then.
Then we can start with that. Yeah.
Can you give me 5 minutes time?
Sure,
that I
sure,
can
sure,
reach
sure.
home?
Yeah, sure, sir. We can do by the time a case presentation by Dr. Megha. So I would welcome Dr. Megha. She is a retina consultant at PC Sharma Eye Hospital, Ambala, and she's an excellent surgeon, a young ophthalmologist. So I would like her to present her case.
Thank you, ma'am. Are my slides visible?
Yes.
Yes, they are visible.
So good evening to all my seniors and colleagues. I would like to thank Ambala Ophthalmological Society and Novartis to give me an opportunity to present my initial experience in this new drug. I'll be presenting 3 cases. The first of which is a 71-year-old male who came to us with the complaints of blurring of vision in his left eye since 3 to 4 months. There's a past history of he had been treated with aflibercept injections in his right eye elsewhere 1 year back. And for his left eye, he had been given 2 intravitreal Avastin injections in his left eye in August and September 2020. He came for a second opinion to us. This was his fundus picture in right and left eye. The right eye showed scarred CNVM with a vision of counting fingers at 3 meters in his right eye. Left vision fluid, which was seen on OCT. The OCT showed pockets of subretinal fluid and subtle PED, and his vision was 636. At this point of time, we completed the 3rd dose of Avastin, and which was given on 30th October. After 1 month of follow-up, the subretinal fluid pockets did not change much in, there was not much reduction, and his vision was also stable on 636 only. And at this point of time, we counsel the patient for this new drug, brolucizumab. So the patient came back after understanding all the pros and cons of this injection. The patient came back to us after a week, and we gave the first injection on 12th of December 2020. So this is the next day OCT picture. You can see significant reduction of the subretinal fluid, subfoveally as well as nasal to fovea. And his vision had also improved from 636 to 624. The patient was quite happy with the vision by next day itself. This is this 2 weeks follow-up when his vision had improved from 636 to 612, and the SRF had completely resolved. The width and height of the PED had also reduced significantly from the first visit. After this, we had called the patient for after 2 weeks to give the second injection, second dose, but unfortunately, he turned up after a month. His vision was stable. There was no evidence of SRF, but we could see some amount of intraretinal edema. So we counseled the patient again for the second dose, second loading dose, and he came to us on 17th of February 2021. That is about 2 months from the first dose, and his vision had also dropped from 612 to 618. So we gave the second dose of brolucizumab at this point of time. On the and last follow-up we have today itself, and his subretinal fluid has completely resolved, and there is still the PD was well and didn't count any. So coming to my second case, this was a male patient, 70 years old male. He was since September 2009. For presentation, his vision was 6 with some drusen on the posterior pole, and in left eye, his vision was 636 with the CNVM complex. So this was his first presentation. We counseled him and gave him 3 doses of Lucentis, first on 11th of September, then 16th of October. The second dose was given, and then the third dose was given on 20th of November. So after 3 doses of Lucentis, the SRF had completely resolved. His vision was improved from 636 to 69, and the patient was quite happy. So we gave the 4 after 6 of previous injections, stable was minor PED, which was seen. There was no evidence of subretinal fluid. So we went ahead with the next dose. He was again called after 6 weeks, but he could not come to us due to the lockdown condition. When he came to us, it was in about 3 months, 3.5 months from the previous injection, and he complained of blurring of vision in this eye since 1 month. His vision had dropped to 618, and if you can appreciate, there is a pocket of SRF right here. So we gave the next dose and counseled the patient that because of the delay in the treatment, his vision was reducing and he needs monthly injections. We gave monthly injections of Lucentis on 19th of June and then 25th of July. His vision improved, he was satisfied, but there were still some pockets of SRF. We had called him after a month itself. Patient came slightly late. Also increased. He complained of failure now, and his vision had dropped 12. So at this point of time, I advised him aflibercept injection. He did not turn up for the next 3 months to us, and in December 2020, he came to us with this similar picture. Not much of the changes were seen, and because we had seen good results from my first injection, so I counseled him from the first case. So I counseled him for this new drug, and we gave this new drug to him on 2nd of January 2021. So this is the OCT picture on the first day when the injection was given. These are the serial OCT pictures. This is on 3rd of January 2021, next day follow-up, 15 days follow-up, and 1 month follow-up. 1 month, his vision had improved from 612 to 69. There was no evidence of subretinal fluid, but the notching in the PED was still present, and he still complained of metamorphopsia, which was his main complaint. We had advised this patient for the second dose, but he has not turned up as of now. So coming to my third case, this is a case of 57-year-old female who was under our treatment since 2014. She had been given multiple injections, both Avastin followed by Lucentis. She was stable on treat and extend regimen till 2018. But in 2018, she was lost to follow-up to us for about 4 to 5 months and came back to us in December 2018. This was her fundus photo. There was a large subretinal hemorrhage along the inferior arcade, a lot of fibrosis and exudation at the macula, and her vision had dropped from 624 to CF at 1 meters. So we did an angiography and ICG was done, and clearly some polyps were seen. So we advised her treatment of aflibercept, 3 loading doses, and PDT, which was done at AIMS. So this is the post-PDT picture. So you can see the subretinal fluid has resolved completely. The PEDs have settled. And this is after the second dose. And this is the inferior picture where there was subretinal hemorrhage and everything. So all these polyps and everything, PEDs have resolved. The subretinal fluid had vanished. So she completed her 3rd dose in March 2019 of aflibercept. And this is a pre and post 3 loading doses and PDT treatment. The subretinal hemorrhage had resolved. Her vision had improved to 660, but there was some subretinal fibrosis due to which her vision did not go back to what it was, that is 618, when she was stable on treatment. So she was kept on the same treatment. After 2 months, she was given the 4th dose. And after that, she was lost to follow up to us. She had went to Germany and for about 6 months, and after that she was stuck in the lockdown there itself. So she came back to us directly on December 2020. So this was her picture in December 2020. You can see a lot of exudation at the macula. There were large PEDs, and fibrosis with pigmentary changes at the macula. So at this point of time, nothing much could be done, and the patient was counseled that injections may or might not help. But her son had already researched this molecule of brolucizumab, and he was very persistent to get this injection done. So this was the first case I had given a PCV injection. So this injection had been given recently on 28th of February 2021, and this is her OCT picture at that time. And this is after 2 to 3 days. You can see the cystic spaces have significantly reduced. There's this pocket of SRF which has resolved, and still for a third day, I think it's a good improvement, and we are waiting for her next follow-ups. So the main points of discussions, I believe, after my initial and early experience, that I have not given any injections in treatment naive eyes. These are already treated eyes, and this drug shows good results in already treated eyes also. So I believe it may work wonders in treatment naive eyes. Secondly, the schedule for post-operative follow-up should be very strict. That is day 1, day 14, and day 30. This is basically to look for any intraocular inflammation, because this injection shows about a 4% intraocular inflammation in the Hawk and Harrier trials. So the patient should be told clearly and explained every symptom like and the come immediately if any. So all in all, this new drug is a favorable alternative with good anatomical as well as visual outcomes, combining with prolonged duration of effect. Thereby decreases financial burden on the patient. Thus, it may improve the compliance of the patient to the therapy. Thank you.
Thank you, Dr. Megha. You have really motivated us. And looking forward for good cases. Good evening, Dr. Shubhendu. We welcome you for your talk. To introduce him, that he is a senior VR consultant in Disha Eye Hospital, Calcutta. He has been presented various papers in national and international conferences. He has been awarded as best paper in various trade conferences. He has always presented, has been awarded as best video in Retina 2019, 2009 and 2010. He has also been awarded with Red Beckler Award in ASCRS 2017. He has various publications to name to his list. He is an excellent surgeon, and I invite you, sir, for your talk.
Thank you very much. So, thank you for giving me the time.
No, sir, it's our privilege.
Yes. Can you see my slides?
Yes.
Yes.
Yes, sir, we can see.
My initial experience with this new drug, brolucizumab. So, Dr. Manoj Khetri, I have gone through all these talks, like almost 80% of the talks, and I have seen the initial part and the last part of the presentation is case discussion also. Because lots of discussions are going on with this new drug, brolucizumab, that is Paganax. And I will share my experience with this new drug. Initially, I tried to use this case in recalcitrant or in recurrent cases, but unfortunately or fortunately, my first patient was a treatment naive patient. This patient actually presented in 2015 with right eye distorted vision, metamorphosia, and the vision was 6/12 parts. On examination, there was subfoveal hemorrhage, CNVM with query. CNVM means was my clinical diagnosis. Left eye was absolutely normal. I advised him for the basic test like DFA and OCT, but he didn't turn up at the time. Again, he came after 4 years, 5 years. He came in September 2020, and at that time the hemorrhage was totally vanished, and this time he did only fundus photography and OCT, and there was thumb-like elevation, PED, and luminescence edema is still there, and I advised him for the ranibizumab. but he turned up at that time again. So in visit 3 October 2020, the vision gone down 6/18, and then he came for active treatment. Then I've advised him for like, it is your choice whether ranibizumab yourself and bolosumab, but it's a new drug. Come, it was the like maiden patient for me, and at that time he took the bolosumab injection. Left eye was absolutely normal. There was no signs of PCV or double layer sense also not there. Vision was absolutely normal 6/6. And after 5 weeks of injection, of 6 milligram, you can see that the blockiness has gone down, but still PED was persisting, and vision improved to 6/9 parts from 6/18. After 11 weeks of this injection, vision was stabilized to 6/9, but PED was persistent, and the blocking was totally resolved. So this was my first patient. It was a treatment-naive patient. Now coming to the case 2, it was a case of a patient presented in 2019 January with 1/60 vision, submacular hemorrhage, almost like not occult CNVM, just kind of like fibrovascular PED, and lots of CME you can see on OCT, and then he took 6 injection of ranibizumab and 2 aflibercept in the left eye, and vision from 1/62, it was stabilized to 6/24. And in September 2020 also, the vision was stabilized to 6/18 parts. But again, in October 2020, the vision gone down to 6/24 parts, so there was recurrence of CME. So it was a case of recurrent CNVM, that is occult CNVM. And at that time, I advised him for intravitreal Paganex. And right eye was absolutely normal. There was no double layer sign. It was like kind of PCV or AMD kind of picture. AMD is occult CNVM, but maybe it is PCV kind of picture you can see. And in the just a minute. Yes. Now, in the left eye, after giving this injection, of 2 weeks after giving this injection, vision was stabilized to 6/18. The edema has totally vanished. The PED part is totally vanished. You can see the junction between the neurosens retina and the PED part. It is almost fuzzy, and there are signs of regression of CNVM. After 6 weeks of giving injection, vision was still stabilized to 6/18. You can see the hyper-FF picture in the left eye, and edema was totally vanished. And again, after 16 weeks of single dose of Paganex, you can see the vision was still maintaining 6/18 parts, and there was edema, intraretinal changes was totally absent. And really small changes were there, but the PED part was totally, it was showing the almost CNVM was almost regressed. Now coming to the case 3, that was the longest follow-up till now. I had done that with this single dose of Paganex. It was a case of post-vitrectomy, vitrectomy done for the vitreous hemorrhage as well as submacular hemorrhage. There was an subretinal TPA injection along with the subretinal ranibizumab I have given in this patient. But there was a very huge CNVM scarred membrane you can see in the posterior pole. So vision was very poor, 3/60. And again, after some time, patient was showing the cystoid changes in the neurosensor edema in the month of December 2020. And I have given this Paganex injection. I choose this injection drug because of its nature of that is rapid penetration of the drug, and the smaller molecules, they can go very rapidly into the inside the retina. So in a vitrectomized eye, maybe maybe it will act for a longer time. Although with the other drugs, although I don't have any finance indicators, with the other drugs also this the clearance from the vitreous cavity in the case of vitrectomized eye, maybe it is more. So I choose this drug because of these following reasons. So after 2 weeks of injection, vision improved to 6/60. You can see the cystoid changes was absolutely resolved, and although the scarred membrane was still persisting, and that lumpy macula was still, the nature was still there, but you can see the white subretinal hematoma was also resolved. You can see in the infrared picture in the fundus photograph, of course. Now coming to the fourth case, it was a case of bilateral CNVM after giving multiple injection of ranibizumab. It was a bilateral stable CNVM. Vision was maintaining 6/18 in both eyes and right eye, and 6/9 parts in the left eye. But again, in the month of December 2020, patient was showing some kind of recurrence in the right eye. It's subfoveal SRF, and in the left eye there was aggravation of EED as well as SRF. And after 3 weeks of giving this ranibizumab injection, vision improved to 6/12, and SRF was totally resolved in the right eye. The left eye vision improved to 6/9, and you can see the PED has gone down significantly. Only a small, like thumb-like elevation of PED was there, but you can see the size of the PED has gone down significantly. So now coming to the case 4. It was a case of recurrent CNVM. You can see the multiple PED double layer shine, and SRF was there in the left eye. And after giving this Paganex injection, it was a recurrent case, recurrent of CNVM, and vision improved to 6/12. Although the PED was persisting in this case, but the subfoveal fluid has gone down. You can see that's on OCT angiography also. There is hardly membrane was visible in the last picture, deeper layer, and as well as the choricapillary scan. Now coming to the sixth case, you can see that there's a case of after giving multiple injection of anti-VEGFs, previous aflibercept and ranibizumab. The CNVM was stable. Vision was maintaining 6/9 in the left eye. Right eye there was double layer shine, although there is no frank SRF or interretinal cystoid changes were there. Vision was maintaining 6/9, but this stable CNVM again recurred after in the month of January 21, recently, 2 months back, and vision gone down to 6/9 parts. Vision was the PED part was not much increased, but the SRF was still there. You can see the larger dilated choroidal vessels in the EDI OCT, and after giving this ranibizumab 2 weeks of giving ranibizumab injection, vision improved to 6/9. Although PED was slightly decreased, but SRF has gone down. You can see the dilated choroidal vessels also still present, but still it is decreased in some decrease in the diameter. So after 6 weeks of this injection, patient you can see in the left eye, although right eye was not changed, so untreated eye, the treated eye vision improved to 6/9. So now the PED has also gone down. You can compare the PED part previously, just after giving single dose of this ranibizumab, you can see that gradually this PED part is decreasing. This patient is doing a good follow-up. And it's another case where you can see 64 years old male patient is having SRF and PED still 6/12 parts in the left eye. After 6 weeks of giving this Paganex injection, the vision improved to 6/9, and central thickness has gone down from 228 to 199, and SRF is completely dissolved, and see the PED part has also decreased very much. So till now, I have given 25 injection in a hospital. Total number of ranibizumab given 66, and first 15 patient I did follow up, but other patient is still waiting. Recently given. So recently the number of injections for this Paganex we have increased because of this in cases of recurrent CNVM. I am not prescribing this drug in treatment-naive patient, although it is not like that it should not be given because my maiden patient was a treatment-naive patient. Most of the indications are PCB. I restricted myself PCB or wet AMD. Previous treatment was actually done in all except for my first case. Touch wood, no adverse reaction. It was I faced in my 25 cases till now. Except one case was complaining about some kind of burning sensation, although it is quite evident, it is usual after giving any anti-VEGF injection, but this patient was complaining of burning sensation. It was persisting for 2 weeks. Although the pain, the burning sensation was coming from inside. That was this patient's own language. Not, although it was gone down significantly, but it was still there. And some kind of special consideration should be made with this new drugs, because it is a new drug. We should use it judiciously, because my advice should be only in recalcitrant cases, because a lot of standard drugs are available in the market. So if you use this new drug uh, at a first go, so patient may ask why you have used it. If some kind of, what say, this kind of bad things are happening, so you should be answerable to the patient. So use judiciously, use the standard treatment like other ranibizumab or aflibercept or the time-tested drugs, because this drug is new. And in some studies also, they have shown that a lot of like intraocular adverse reaction. Although the subgroup analysis of the Hawker study also, they have shown the intraocular adverse inflammation, all the vasculitis, all the choroidal ischemia, retinal ischemia. They have shown some AGO also. They have published one case report of choroidal ischemia. Although it was going, I think it's spontaneously, it was resolving with this with the topical steroid. They have used on this topical steroid to treat the inflammation. After 10 weeks, after 8 weeks, the inflammation has appeared, and after 10 weeks of giving this injection, there's this choroidal ischemia part, and the other retinal ischemic part has vanished. So these kind of things we have gone through. So avoiding one-eye patient, if if the seeing eye, the vision is very less, so you can use it, but use it again judiciously. And proper consent. In brief, you should highlight your patient, not telling everything. What is my, because I have seen. If you are telling everything, because you can feel sudden loss of vision, the patient will not turn up for your injection. So you can show this much of injection we have given. Till now, doctor, in the last meeting also with Dr. Rajanarayan, he was telling, till now in India we have used 1,000 injection. Only one patient he has faced one. He has not given, but it is the cumulative data of 100,000 injection in whole India. But in one case, there was hypopion and it was like improving. But other cases, there was no adverse reaction. So if you, there is like people are saying, but still you can tell the adverse reaction, vasculitis, brief to the patient, and it is longer acting. Obviously, it is longer acting. And one more thing I should highlight, that is the frequent follow-up is required, because it's a new drug. I am just asking the patient to do the follow-up after 2 weeks, and over telephone I am just taking taking care with what is their visual status, what is their redness, what any, after every weekly. So these things should be made under special consideration. Thank you.
Thank you, sir. Thank you very much. Good evening. We have Dr. Kapil Vora, Vice President of Ambala Ophthalmic Society, with us. He has joined. Dr. Shubhendu, I would just like to ask, what proper consent? Do we really have any consent formed for this drug till now?
Like in our usual consent for the ranibizumab aflibercept, we have already there is the sudden loss of sudden onset of vision or intraocular inflammation part. That part has been mentioned. So we are using the same consent form for this bullet patient also. If this statement, if you are not, if in your consent form, if you are not included it previously, so include it. Because sudden loss of vision and intraocular inflammation, these two things should be these things should be added. In our consent form, we have already added these statements.
Okay. Yes, Dr. Mohit, we have questions.
Yeah, I was just looking for these questions. We can request notice people if they have any question on the webinar link. Till then, sir, I think so. It was a very nice. You have shown so many cases, PCV, CNBM, so many, and it was doing very well. I think so. There is no doubt that its efficacy is really good. I think the main problem was the adverse event concern, which I think in our population is little less, or maybe we are a little bit
Maybe.
more.
Maybe.
Yeah, maybe.
But what
Because
was
the
my
older
gut
countries-
feelings? This drug is actually very good. Like it will be very, very effective against the PED part. The PED
Yeah.
part, it has other drugs because previously we are not concerned about the PED part. But this drug is worked magically with the PED part. Like I have shown few cases with over the time period of a few weeks, 2 weeks, 4 weeks, 6 weeks. You can see the PED has gone down significantly. Like it's quite nicely. It was, although it was my initial experience, but still it has some potential for this new
My
drug.
concern was that, like, this adverse event thing, though it is very less in our population, but we need to keep them under regular follow-up.
Yes, regular.
The
and
advantage
frequent.
of this, very frequent means every 2 weeks, you mean to say frequently, or how do you are actually doing after 1 month? You have kept patient under follow-up for then every 2 weeks only you keep after 1 month also, or how do you do that?
2 weeks, 4 weeks, 6 weeks, then 3 months.
Okay. And I think so till then also we have to tell the patient also very nicely if you have any symptoms, they have to call us.
Yes,
And because
yes.
the adverse events can occur very late also. That is a problem. That is not that will occur only within
8 to 10
few
weeks.
days.
Yes, that 3 to 4 months. That part is also.
Yeah. So it is just a very good molecule in PCV also. And today just notice people told that they got this approval for PCV also now. So I think so in PCV it is a very good molecule. Even your cases also we could see that.
In some part of our country that people are using in off-label use in BRVO or DME also, but we have restricted ourselves to only PCV and CNVM, not to create any further controversy.
Sir,
Does
do
it
you
have any effect?
prefer do you prefer giving 3 loading doses as monthly interval and then extending the treatment, or how are you doing in your cases?
Like in our case series, like it is all with the single drug. That was, I have not injected monthly dose because with the only single drug, the patient is responding, and the response is initially it was and it was sustaining for last 4 months. I have highlighted one case 2, I think. The patient was doing very well with only single dose of rhodosilimab. So you can highlight whatever maybe the study, like they're saying in the Hawk area also, you can build up your own experience, like you can conscious from your own experience. Like patients are doing very well with the single dose, and even with this only 1 dose, they're maintaining good vision, stabilized for 3 to 4 months. That is, you can highlight in this manner also. You can reduce the frequency of the drug injection. That is the main. You have to increase the gap between the injection. So sometimes the patients are doing like they are actually fed up with this injection, lots of 16, 20, 30 injections. So these kind of patient, you can just highlight. You can reduce the number of injection. Maybe it will be okay for your next 3 months or 4 months. So not like that every monthly you have to give the injection. Although in the study, Hawk area study, they have mentioned the monthly dose so that 3 injections so that you can maintain the vision up to the 96 weeks. But practically it is happening with the single dose. It's a very good drug. It has got lots of potential, I think so, with this new drug.
Okay. Dr. Manoj, are you there?
Yes, I'm there.
Okay, I just wanted to ask, what is your take on this? Whether giving monthly injections and then going for or treat and extend?
No, definitely, even with brolucizumab, we are taking loading dose as of now. That is monthly injections for 3 months and then only going on. Because one is the data which is suggesting to do the same. The second thing, we ourselves has to learn from some, at least for 6 months to a year's time, like how it is working. And my practice was never PRN. I always used to do monthly loading and followed by PRN. The same thing I'm following as of now.
Okay.
So, do you have any exclusion criteria or any specific criteria?
Yeah, so I'm not too concerned about one-eyed patient, but I'm concerned about any patient who had a old vein occlusion in the past in either of the eyes. That is one of the relative contraindications what most of the people are from clinical experience are telling. And if you talk to a lot of colleagues from US, they are doing only as a switchover therapy as of now on brolucizumab. Mostly for recalcitrant cases. There are very few patients, rather less than 20% of their patients are on treatment naive patients who have got brolucizumab due to various issues there. But here, I think we have also started for treatment naive eyes. So seeing every patient, as I said in my talk, individually and excluding any vein occlusion, and then definitely uveitis is there. No brolucizumab, any kind of uveitis in the past, but also looking for vein occlusions. They are saying like as vasculitis is one of the major feature, and we know vasculitis is one of the major etiological factor for vein occlusion. So to exclude those patients like
Sir,
that.
have you any
I want to
encountered any
add one.
cases, sir?
Yes, please, Subhendu, please add.
Basically, I want to add one more contraindication. Recently operated patient. That is the signs of inflammation, maybe more. So you can, because Dr. Rajanaran also showing one case. The 6 weeks back, the cataract surgery has been done, and he has given the brolucizumab injection, and patient presented with the hyperpion. So there may be aggravation of the uveitis. So like maybe it was not at all an infected case because the patient was improved with the topical drugs only without, so it was not infected.
Sir, have you encountered any cases with vitreous cells or like that? Any vitreous inflammation?
No.
As of touch wood, as
That's
of now.
great. So how do you counsel your patients? Like Dr. Subhendru very rightly said that you cannot tell everything because otherwise patient will run away. It's very difficult, like how to tell
Yes,
these
you have
things.
to brief. You have to brief the whole thing in a very nutshell. Like you cannot. It's better
I will
not
tell you,
to like.
two patients of mine who have also read on net, and they came to us and they asked that molecule, why don't you inject that for us? So that kind of literacy is also there. So
Yes, absolutely. So we need to be medico-legally also very strong because
Yes.
in consent it should be very clearly mentioned. I think so, and we should document that there is no past history.
I don't think there is a much of medico-legally there is not much of advice. Like we are hearing lot many reports that our colleagues are giving for various indications. Let's stick to only neovascular AMD as of now. So if you're sticking to that, I think medico-legally it should not be a problem. And now it's been approved for IPCV also. Pigeon-X, that brolucizumab has got IPCV approval also. So that's not a problem. It should not be an issue.
There is a question from Dr. Sumit Khanduja that have you tried this molecule in any other pathology other than ARMD? Dr. Shubhendu, I think
No.
I will not advise also. Let's wait, not only for medical, but we are not sure. Let's wait for the DME data. I think by this year end, we are going to have data from the DME trials. It's already going on. And the preliminary results, let's wait for that data, and then only we should take a call how to inject for other various indications.
So right now we should restrict ourselves to wet ARMD,
Yes.
preferably
Yes.
resistant and PCV.
Yeah, let's do that. Yeah, a few of our colleagues have injected even for BRBO and other indications, but I will say let's not do that. Let's not do that. It's not correct.
Currently, PCB and neovascular AMD are only the approved indication.
Indication. Yeah, let's stick to approved indication.
Sir, just one question in my mind that in PCV patient, I have a patient who has a PCV with large submacular hemorrhage. Do you think this molecule will work in reducing the hemorrhage also? Or do you have such experience?
In submacular hemorrhage, if it is very large, more than 4 inch diameter, yes, I am recommending surgery, that is subretinal TPA with anti-VEGF and air. And if it is very large, then go for the temporal relaxing retinectomy and removal of subretinal neovascular membrane as well as blood. And if it is very old, like more than 8 weeks and never detected attachment, if possible, that RP chloride graft transplantation. These three cases, like here, submacular hemorrhage, if it is less than 46 diameter small, you can try with anti-VEGF, or if it is traumatic in origin, you can go for the like intravitreal secretory gas. Otherwise, Brolucimab, I never tried for the submacular hemorrhage.
Do you have any question?
Dr. Mohit, any question?
Yeah, I'm just saying, I think so. I don't think there are any question right now. I think so. The speakers have really raised, I think so, almost. Yeah, it was everything actually. The cases also we saw almost all the variety, and there were hardly any cases of inflammation. I think so. There's no doubt about the efficacy part, and Dr. Subhendru case is such a long follow-up. Also, the patient are maintaining their vision also, and even there is no edema also. I think so. It is working very well. So I think so. Yeah, we can. I think so, sir. I think so. We can wind up. I think so. There are no more questions from the audience. So, sir, from outside from the Ambala Ophthalmological Society, I would extend my sincere thanks to all the speakers who have really spared their time and really increased our knowledge also about this newer molecule and given us more confidence that we also will start injecting these injections at this our setup. And thank you, Novartis, also that they have been such a nice CME. And hopefully we will have a good interaction physically also when we meet. Thank you everybody for joining.
Let's have a few words from Kapil sir also. Kapil sir is there.
Yeah, yes, sir.
Yeah.
How are you, sir? Kapil sir.
Sir, unmute
Hello, sir.
yourself.
Unmute yourself, sir. Unmute.
Hello, Kapil
Unmute
sir. Hi.
Sir, unmute yourself.
Sir, unmute, yeah.
Sir, unmute कीजिए. Unmute.
Okay. Good evening, greetings, and my regards to all the stalwarts. Manoj boss, seeing you after such a long time. Shubhendu, good evening.
Hello, sir. Hello, sir.
And it was heartening to listen to you. I'm sorry I joined late because got free very late. I was very late in the OT today, and it was heartening to listen to you. You all our savior. You all posterior segment masters are our saviors basically. So you very often take us out of trouble. Thanks a lot, and all the best for the future meetings.